Thank you so much for having me. I'd like to thank my co-authors. My name is Sarav Shah, coming to you from New England Baptist Hospital in Boston, Massachusetts, in the United States. So as we get started, the gap in the literature, there are a few cost-effectiveness studies to evaluate real-world suture constructs and anchors, as well as their short and long-term cost effectiveness. Without a direct comparison of the real-world constructs, surgeons may be inclined to believe that these constructs are similar and thus more susceptible to industry sponsorship. So the goals of this project was to evaluate the cost effectiveness of rotator cuff repair by utilizing real-world cost analysis and real-world possibilities for commercially surgical constructs for arthroscopic rotator cuff repair sorted by tear size. So the study design was an economic and decision analysis, a Markov model based on 10,000 iterations. So the real-world cost data and previously published data on both anchor failure strength and re-tear rates by tear size and constructs were input into a Markov model with time points of 1, 5, and 10 years. Cost effectiveness was assessed in terms of cost per quality adjusted life year, and the health states included intact repair, asymptomatic or symptomatic re-tear, revision, repair, and cup tear arthropathy. So all constructs were included knotted and knotless single row and double row constructs using anchors from three major companies, Smith & Nephew, Arthrex, and Stryker. Here's what the model looked like in terms of single row and double row anchors based on tear size. The anchor costs were derived using real-world cost data from the hospital, high-volume academic institution. The model assumed that rotator cuff repair patients transitioned into 4 initial health states after initial repair: intact, asymptomatic re-tear, symptomatic re-tear, or death. Patients then either remained in these states or transitioned to re-tear, revision, cup tear arthropathy, or death. The model allowed for patients to undergo maximum 1 revision, used a 1-year length of cycle, and considered 1, 5, and 10-year time points. The base case for the study was a 56-year-old male and assumes that all patients are appropriately indicated for surgery, otherwise healthy, do not have associated shoulder pathology such as labral tears or instability. Here's just a representation of the model. And then here's the kind of iterations of how it can go through, again, allowing for only 1 revision. So the transition probabilities were entered for developing either asymptomatic or symptomatic re-tear after surgery, derived in multifactorial manner based on tear size, construct, and suture anchor. Published study review was done in English in all studies published in PubMed after 2011. These studies were mainly sorted to determine final re-tear rates reported by size, construct, and aggregated to determine overall re-tear rates based on anchor and pull-out strength. And these re-tear rates were determined from the literature review and multiplied by calculated modifier to arrive at the final transition probability, as the re-tear rates described were based on size and construct, and then the pull-out strength was determined based on each anchor individually and determined combined to determine these multifactorial modifier. And here's just the statistics that we came up with in terms of percentage-wise for annual probability based on the Markov model. Mortality, you can read what it is, and based on tear size or the re-tear rates, and we included asymptomatic to symptomatic, and then symptomatic to asymptomatic. And then the number one kind of adjuster that we used was quality adjusted life year, and this is used in terms of to justify the cost of the model in the Markov model. And double row repairs cost of additional operative time was accounted for, and all implant costs were used based on the academic center, covering 19 surgeons, primary and revision rotator cuff in the year 2020 and 2021. And all these represented annual costs to the healthcare system. So here's just the example of the anchors that were used for Smith & Nephew. Knotted helicoil, Arthrex knotted was the corkscrew biocomposite, and the knotless anchors you can see there. Those are just the prices differentials based on the institution. But again, this is determined in quality adjusted life year. So every institution is obviously different in terms of cost, but quality adjusted life year kind of balances that out based on just comparison. So the optimal strategy was defined as the dominant strategy as a willingness to pay threshold of less than $50,000 US dollars per quality adjusted life year. That's kind of standard for in terms of cost effectiveness. And the number one question that I usually get based on this study is why not just use the real world data to compare? But this was 10,000 iterations for each construct with each tear size. So you'd have to multiply that by 6. That'd be 60,000 patients. I don't think any institution has 60,000 patients with 5 and 10 year follow-up. So these diagrams were used just as an example. Here's kind of the strategies that, for small tear, 10 years using 2021 dollars. So the double row knotted by Arthrex was the most cost effective at 10 years. In the medium tears, again, double row knotted from Arthrex was the most cost effective. I don't know why that popped up. Okay. Large tears, double row knotless was the most cost effectiveness in terms of large tears, and then in massive tears, double row knotless in terms of Smith and Nephew was the most cost effective. So limitations, it's not clear what proportion of re-tears occur due to mechanical failure versus biologic failure. In that light, it should be noted that we selected a limit for how much failure strength may affect the re-tear rate, as obviously, the stronger it doesn't prevent the re-tear rate to X amount. And we did not consider factors such as biologic augments, including injectables and or scaffolds. Although we factored in operative time difference between single and double row constructs, we did not compare operative times for knotless versus knotted constructs. And then we did not account for patient factors such as degree of fatty infiltration. So some of the takeaways: in small tears, the corkscrew biocomposite with swivel lock biocomposite double row knotted Arthrex strategy was the most cost effective and least expensive strategy at 10 years for small tears. For medium tears, it was the corkscrew biocomposite with swivel lock biocomposite double row knotted, meaning tied construct was optimal, but it was also equivalent efficacy to the swivel lock biocomposite single row knotless and was of similar price. In the large and massive tears, there were multiple commercial implant companies where double row knotless strategies were considered optimal. Thank you.